Hello, my name's Rasha Al-Lamee and I'm based at Imperial College in London and I'm one of the deputy editors from JACC. It's my absolute pleasure today to be joined by Professor Valentin Fuster, who's president of the Mount Sinai Fuster Heart Institution and also physician-in-chief at the Mount Sinai Medical Centre and of course the previous editor of JACC. Professor Fuster, thank you for joining me here today.
Thank you.
So today we're here to talk about the new acute coronary syndrome guidelines published by ACC and AHA. And of course, we've been waiting for a long time for these guidelines. I know that you've recently written an editorial in JACC around those guidelines, and perhaps you can tell us a little bit about what you thought. And they're long awaited. And are you happy with what you see?
I'm very happy to have these guidelines from ACC, AHA, and other organizations. It's an excellent document and was time because the previous document from the ACC, AHA was in 2013. And actually the European Society of Cardiology document was in 2023. So it is interesting to compare the new document now, very new, from 2025 ACC-AHA with the document of the European Society of Cardiology, which is 2023. And the comparison tells me are so equal, so similar, that actually I think is very rewarding. And this brings up the issue, which I point out in the editorial with Dr. Borja Ibanez from the previous ACC, was chair of the previous ACC guideline on acute coronary syndromes. And we discussed together about this combination this time, and we say it's not a combination, it's the same. Let's move on into having a single type of guideline in the future. And this reminds me, because I was the first who actually was the chair of the first guidelines. It was transatlantic, ACC, AHA, European Society on Atrial Fibrillation many years ago. And at that time, I wanted to make a prediction that from then on we would work together. Well, it didn't happen, but my plea comes again. This is the time to join forces. So going back into the details, both guidelines really point out into a single entity, acute coronary syndrome, which is a STEMI, non-STEMI, unstable angina. And then there are so many similarities, for example, on issues that are very controversial, like platelet inhibition following PCI or acute myocardial infarction, which is so many possibilities that one can do. Both end up saying 12 months of dual antiplatelet therapy, and then should be individualized when to start, when to finish, depending on the patient. And this is very, very nice indeed. And this brings the question that whether European and American guidelines should be only together. I think they should be, but we should entail other countries and other communities. So I think that from now on, whenever we have guidelines, we should somehow include other communities which may be different in terms of guidelines. What are the similarities and what should not be similar? And I think this is actually is needed. One thing that the American guidelines have to learn from the European guidelines, for example, is the European guidelines come very often, and particularly during the meetings. The exposure is excellent. So many people are able to be aware of what's going on, while the American guidelines not necessarily came out during the American Heart Association or the American College of Cardiology. So I think this is something that the American guidelines should learn. The other issue, I think both guidelines involve in the committees people from many regions in the world. I think this is very important. But I think perhaps the European guidelines have already executive comments that go to different countries. And I think this is something that the American guidelines also should look at. These are the many similarities and very few differences.
And thank you, Professor Fuster. You also pointed out in your editorial some of the differences, particularly in terms of the recommendations for dual antiplatelet therapy post ACS. And I found it interesting that you discussed that within the European guidelines, they were very clear about what evidence base they'd use to come to their various conclusions. And perhaps in the American guidelines, we needed a bit more of that detail. Could you speak to a little bit of that?
Well, you are calling from London, so you are biased for the European guidelines. Yeah, there is a difference, I think. It's interesting difference, actually. The European guidelines tend to explain why, for example, one medication versus the other, or one entity versus the other, in a way that is fully understood and displayed. American guidelines perhaps don't have so much explanation. And I think I pointed out in the editorial prasugrel versus ticagrelor. Perhaps one difference that I pointed out in the editorial is prasugrel versus ticagrelor in acute coronary syndromes and complex disease, where there's only one trial that mentions prasugrel is superior to ticagrelor. There's no other trial. Well, in the American guidelines, it's like there is no difference. And I think they should point out, well, there is a difference, and this is the trial that shows the difference. But certainly for us, or for a doctor as a consumer, will say, well, there is no difference. Let me use ticagrelor because it's more commonly used here in the United States. So there's some differences in the explanation of one aspect versus the others, and this is throughout the guidelines. But I wouldn't say this is very frequent, however.
Thank you very, very much, Professor Fuster. It's been a pleasure to be with you today. Thank you very much again for providing a very thoughtful editorial for JACC, and I'm sure the readers will very much enjoy reading it. Thank you very much for watching us today.
Thank you.